Good afternoon to all of you. Like I said, this is the last session of the day. Unfortunately, it is the lunch session as well. So we hope to make it as concise and interesting as possible. So the topic that I have chosen for my IC is socket. I'm sure when all of you come have a patient who comes with a socket, you're absolutely bewildered, not knowing what to do next. So this is our attempt to make things simpler for you. So as our first speaker, we have Dr. Shebin. I'm privileged to call her because we did our fellowship together, as well as now she's the consultant at Giridhar Eye Hospital. She'll be taking you through the approach to socket evaluation.
Thank you, Anshu. Thank you for this kind opportunity. So, absence of an eye or a shrunken, non-functional eye due to any etiologies is an exceptionally difficult situation for a patient. So, what is a socket? A hole or a curved opening that holds something. So, here the bony socket is holding the globe. Now, what is an ideal anophthalmic socket? It should contain an adequate size orbital implant with a healthy conjunctival lining and well-formed fornices. And there are a few other criteria also, including a good prosthesis with satisfactory movement, a symmetric supratarsal eyelid fold, normal tone and position of the eyelids and lid margin and lashes. So what is contracted socket? So it's a shrinkage of bony orbital or the orbital soft tissues with a decrease in volume or surface and inability to place or retain a reasonably sized prosthesis. Now let us see how we can classify the contracted socket. It could be a congenital or acquired, ophthalmic or anophthalmic. Ophthalmic is when there is a globe, a thizical or shrunken globe is there. Anophthalmic is when there is no globe. This can also be classified into soft tissue contracture, bony contracture and combined. Again, this could be a wet socket or a dry one. So the congenital etiologies is anophthalmos and microphthalmos. For acquired contracted socket, there are many reasons. We can broadly classify them into etiology related, prosthesis and implant related, iatrogenic and ocular surface related. Now we have the morphological classification where this can be an anophthalmic socket following enucleation and evisceration, ophthalmic following trauma or chemical and irradiation injury, microphthalmic in case of congenital microphthalmos or microcornea. Hypoplastic is congenital underdevelopment of the bony socket. This is an accentrated socket. This is the most commonly used classification, Gopalakrishna classification, where grade 0 is normal or an ideal socket. Grade 1 is shallowing or shelving of the inferior fornix. Shelving is doesn't mean there is contraction, it just means there is a lower lid eversion. 2 is shortening of both superior and inferior fornix. 3 is shortening of all 4 fornices. 4 is when this is associated with the reduced vertical and horizontal palpable fissure. 5 is a refractory contracted socket, most often following multiple socket surgeries. So before going to evaluation, we should know this term that what is post-enucleation socket syndrome or anophthalmic socket syndrome. So this can happen following enucleation surgery with implant or without implant. So what basically happens here is initially there will be a posterior migration of the orbital soft tissues and then inferior and then anterior. So these soft tissues will be coming inferiorly and pushing in the lower fornix. So there will be anterior tilt of the inferior edge of the prosthesis, posterior tilt at the superior edge. There will be deepening of the upper lid sulcus. There can be associated ptosis and shallow inferior fornix and lower lid eversion or ectropion. So how do they present? They can present with a poor cosmesis or an extruding or ill-fitting prosthesis because of an exposed or extrusion of the implant or because of an orbital mass or sometimes because of giant papillary conjunctivitis. Giant papillary conjunctivitis usually due to hypersensitivity reactions to proteins on the ocular prosthesis. And there can be pain. Pain can be due to a variety of reasons including ill-fitting prosthesis, implant exposure or infected implant. There can be trochleitis because of the prosthesis or the orbital implant pressing over the trochlear region. Could be a phantom pain or a dry anophthalmic socket syndrome. Could be a recurrence of the orbital malignancies or if we cannot find any etiologies, could be because of psychiatric issues also. So detailed history is very important regarding the onset, duration and progression of the complaints, whether it is a congenital or an acquired one, how the patient is handling the prosthesis, how often patient is taking out and cleaning the prosthesis because Frequent manipulation again will lead to loss of the polish. This can again cause further irritation to the socket and increases the discharge. When is the last polishing done, whether the patient is using any lubricating eye drops or protective glasses? What about the prior surgeries, any history of trauma, radiation, and also systemic disease? Yeah, lubricating drops is important because the patient will be having a reduced tear production because of the absent corneal reflex. So there can be two scenarios. One is with patient is coming with prosthesis and without prosthesis. So if the patient is coming with prosthesis, we should evaluate with the prosthesis. So here we can see that they are having a very good cosmesis in the first picture, but in the second picture the cosmesis is poor. Color match is good in both eyes, but here we can see that the corneal color matching is poor. Then how is the movement? If it is excellent or it is conversational, how is whether there is any lag of thalamus, enophthalmos, you can see it in the inspection worm's eye view or can measure with a Hertel sex ophthalmometer. And finally about the lid, how is there is entropion, ectropion, if there is any ptosis. Again, once it is done, remove the prosthesis and examine the socket, whether it is ophthalmic socket, anophthalmic socket, how is the surface, or it is an accentrated socket, how is the surface, if there is any papillae, congestion, granulomas, then how is the phonesis. Then palpate for the implant, whether it is central, if it is dislocated, whether it is well covered with the conjunctiva, and even if it is a thysicali, check for the movements, because this will give you an idea about whether the patient will be having any movement following the surgery, and also if there is any swelling. Now evaluation processes, Ms. Celia will be detailing it later, but briefly we should look for what is the type of prosthesis, surface, edges, size, shape. Now finally the ptosis could be a true ptosis here or a pseudotosis. True ptosis could be because of laxity of the fibrous connective tissue, prior trauma, senile dehiscence, or because of the frequent handling. So first always correct the volume and reassess ptosis. Again, the socket can be, there is some terminology known as DAS, dry anophthalmic socket syndrome. This occurs because of reduced meibomian gland density, absent corneal tear reflex, reduced blinking, and log ophthalmos. So finally, what at the end of your evaluation, what matters is whether there is a contracture of the surface or volume or both, because that is how you are going to manage. Thank you.
Thank you, Dr. Shibin, for that wonderful coverage on the topic. Now I invite Dr. Anju. She is a consultant oculoplasty in Comtrist Eye Hospital. She's my colleague. She'll be talking on evisceration, enucleation. Over to you.
Yeah, so once again, good afternoon to everybody. Actually, this is mainly intended at educating the general ophthalmologist, while I see the majority are oculoplastic surgeons. So it will be more an interactive one where you can add in your points at the end. We'll quickly run through evisceration and enucleation. So enucleation was the oldest surgery performed in ophthalmology in the 2600 BC. So later in the 19th century, that was when Baer introduced evisceration, when he encountered an expulsive hemorrhage. Not very soon after, Noyes described evisceration for the management of intraocular infections. And in a decade later, the first implant was placed, which was a glass sphere into the eviscerated cavity. So this Shebin already beautifully described about how we have the orbit, the eyeball, and the other contents, and how we need to know the volume that we need that is there, and how much we need to replenish. So about enucleation, it is a surgical procedure which involves removing the entire globe and its intraocular contents, preserving all the other periorbital and the orbital structures. So you can see how the structures which are indicated in blue and violet are the ones that are being removed. The primary indications of enucleation are intraocular tumors, especially choroidal melanoma and retinoblastoma group E, which do not respond to other treatments. And trauma, we generally do not do an enucleation unless and until the globe cannot be salvaged. And painful blind eye conditions, but now it is a relative indication. Yes, of course, as part of an eye donation, we remove the entire globe. It is contraindicated when you have an intraocular malignancy with evidence of orbital spread. In that case, you should consider an exenteration. What are the prerequisites? So when you have a patient who you're likely to advise an evisceration, we need to have an imaging in the form of an ultrasound B scan or an MRI. B-scan is available right there in most of our hospitals, so you can get a good idea about the intraocular contents. Also, you can measure the axial length. And the axial length, when I say that, we need to measure the axial length of the other eye because it will guide us as to what size of implant that you need to place. And it is always important to take at least 2 ophthalmologists' opinion because this is a cyclodestructive procedure and there are medico-legal aspects to it. Like I said, an informed consent, a detailed preoperative workup, general anesthesia if it's a child or if the patient has low tolerance to pain. You can also add sedation to your local anesthesia. The need to stop antiplatelets and NSAIDs prior to the procedure to avoid intraop and perioperative bleeding. And a detailed psychological counseling is very important because the patient is ultimately losing an eye. So we need to empathize with them and also tell them what they need to expect and do for their lifetime. This is a quick surgical video which shows enucleation by the myoconjunctival technique. So you begin by so before you begin the procedure, always do a timeout. Make sure that it is the right eye. It needs to be dilated and you need to ensure whether your diagnosis is right before you carry on with the procedure. So in order to reduce the bleeding, you can always go ahead and put in topical brimonidine. A 360-degree conjunctival peritomy is done and then the tenons is separated. Then you begin by tagging your rectus muscles one by one. So make sure that you tag them at least 2 to 3 millimeters away because in most cases you're dealing with intraocular tumors. You do not want any inadvertent injury to the globe. So after tagging all the 4 recti muscles, then the oblique muscles are then identified and disinserted. So gently with the help of enucleation scissors, you strum the optic nerve. We go all the way up till the orbital apex, but we do not cut there because if you are to cut there, then you are likely to damage the structures at the superior orbital fissure, which can lead to intratractable bleeding as well as post-op nerve palsies that can occur. So after this, the closure of the conjunctiva and tenons are also done. And this being a myoconjunctival technique, the recti muscles where we had initially tagged are now being taken through the conjunctiva. This is done to ensure that the patient has prosthesis mobility in the post-op period. So histopathological examination, it is important whatever structure that we remove from the body, it's always better to have the backing of a histopathological report. You need to know the extent and that might alter your management. Postoperative care is pretty much the same both in enucleation and evisceration. Oral analgesia, you can give broad spectrum antibiotic prophylaxis if you're dealing with infection. A pressure patch would take care of the initial edema. You can take it at 24 hours, 3 days to 1 week, and then amp up with topical antibiotic and corticosteroid drops. Coming to evisceration, it is basically the removal of all the cornea and all the intraocular contents, leaving behind the sclera and the other structures of the eye. So indications, the absolute contraindication is by now, which you are aware, it's the intraocular tumors and those with orbital spreads. The rest of the indications are endophthalmitis, when you have a painful blind eye, phthisis bulbi, especially for cosmetic concerns. So evisceration consent form similarly, so not just one in English, you should have one in the vernacular language as well, because you need to make sure that the patients know what they're undergoing. So this is a step-by-step pictorial representation. So steps are more or less the same in the beginning, where you take a 360-degree conjunctival peritomy. After that, a stab incision is made into the cornea, and whereby the cornea button is then taken out. Then with the help of an evisceration scoop, you can scoop out all the contents. And it is very important to make sure that you have devitalized the uveal tissues, so make use of alcohol swabs and wash them thoroughly without touching the rest of the tissues outside. And once this is done, then the next thing is to make your petals. So now the common trend is towards a 4-petal technique, wherein the optic nerve is being disinserted posteriorly. This is to give more volume and also to avoid bleeding from the vessel supplying the optic nerve. and then the flaps are fashioned in such a manner that the rectus muscles are attached to each of the flaps. They are then closed by double breasting technique. We can use 5-0 vicryl, and then the conjunctiva is closed using either continuous 6-0 vicryl sutures or interrupted as per your liking. So a couple of things when you do this: minimum handling of the tissue. Make sure that you do not crush the tissues and cause inadvertent damage, because we need to preserve as much conjunctiva as possible. Any unnecessary meddling is going to cause you a contracted socket, and that will impede the fitting of a good prosthesis. And at the end of the procedure, always keep in a conformer so that the cornices are maintained. So I'll be skipping this technique, the video, in interest of time. A specimen examination, I like to send all the specimens for histopathological as well as microbiological, especially when you're doing it for an infection. So quickly about implants. So you're basically trying to replace a missing biological structure, and orbital implants are used to give that volume. So 70 to 80% of the globe volume is what you want to replace. Quick calculation would be: for enucleation, axial length minus 3 millimeters, and evisceration will be axial length minus 2 millimeters. You have varying sizes of sizes that are available, which will give you an idea as to what implant size you need to put in. So there are various types of implants that are available based on the porosity. You have porous ones and non-porous ones. And you also, the biogenic implant that we have is the dermis fat graft. So just quickly about orbital implants based on integration. You have non-integrated, integrated, and quasi-integrated. So non-integrated ones are where it is a well-rounded implant and the prosthesis is just placed over it. Whereas an integrated one is where you use materials. So in a non-integrated one, you have the PMMA silicone, and in integrated you have hydroxyapatite, which is porous, and it is a second step procedure wherein you have to do pegging and then place your prosthesis. And quasi-integrated is where you have prosthesis such as the Allen in Iowa, which have indentations on them, which will give quasi-integrated feel, and accordingly modifications are made in your prosthesis as well. So complications, pretty much Shebin has already covered most of this. I'll quickly run through this. So these were just our patients who had undergone evisceration and enucleation and who were fitted with prosthesis, and Celia will be talking to you in detail about that. Thank you.
Thank you, Anju, for that detailed description on enucleation evisceration. Next, we have Dr. Marian Poli. She is the HOD of Oculoplasty Orbit and Ocular Oncology, Giridhara Institute. She needs no introduction. Welcome, ma'am.
Yeah, hi. Last session, Okay, this is socket reconstruction. Okay. Introduction is like, it's a broad terminology. It includes modification of the prosthesis, surgical, and then combined, both surgery and modification of the prosthesis. So this is stock shell modified to customized. So coming to the principles of socket surgery. So either we have to replace the mucosal lining, or we have to correct the volume and make the fornices. Sometimes all the three has to be done in some of the cases. So this is first a fornix forming suture. Here patient not really bothered about the volume. Lining is adequate. He just wants the shell to be fitted in. So in that case, you can get away with just a simple fornix forming suture. So suture start from the fornix. You can pull tie over the bolsters and come to the skin side. This I'll show in the mucous membrane video. So next is replacement of lining. So in this case, here also the patient's expectations are very less. He just want a prosthesis to be fitted, but without adequate lining, it will not stay. So I just did a mucous membrane graft, and then prosthesis was fitted. So why mucous membrane graft? It's easily accessible, and the donor site will easily epithelialize in 2 to 3 weeks time. The only thing, we have to be very careful when you take this thing, because you have to avoid damage to parotid duct. This opening is opposite to the upper second molar tooth when harvesting a mucous membrane graft. This is a short video. Mark some days we do under local anesthesia also. General anesthesia is not really mandatory for a mucous membrane graft. After marking submucosal infiltration, then I use a number 15 blade. Problem with the cauteries induces scarring, and you will not get the correct plane sometimes. Then the mucous membrane graft is lifted up. Take care, don't include too much of submucosal tissues. If you're taking too much of submucosal tissues, sometimes if you go deep, numbness will happen. Then defight the mucous membrane graft. And if it is a small defect, just suture it with the Vicryl 50 or 60. So nowadays I mostly use amniotic membrane with glue, and it is very comfortable for the patient. So coming to the socket, incision with number 15 blade. If possible, don't use too much cautery. Then dissect. Reach the fornix. Dissect both sides, superiorly and inferiorly, and keep the mucous membrane graft, and then suture it. And you have to take the fornix forming suture also. The suture should pass through the periosteum, and tie over bolsters. This our skin suture, either you can bury it, if you can put a small incision on the skin and bury inside. Then in that case you have to use an absorbable suture. Here I am taking Proline, so I am just tying on over the skin. Postoperatively, avoid hot and spicy food, antiseptic mouthwash. I usually keep the bandage in the socket for 5 days. Oral and systemic oral antibiotics, prosthesis after 6 weeks. So these are the few patients fitted with customized prosthesis after mucous membrane graft. Complications are extremely rare. While I was using suture to close the mucous membrane area, I was getting 1 or 2 granulomas. But nowadays I mostly use amniotic membrane, so not much problems. Orbital implants, we have heard from Dr. Anju, can be primary or secondary. So primary she has already shown following enucleation evisceration. Coming to the secondary implant, so this is a lady, the contracted socket. So what we have done, a secondary ball implant with the fornix forming sutures and fitted with a prosthesis. Similarly, this is a gentleman. He had formic acid injury with had extensive formic acid injury. So presented to us with nectropion, then an anophthalmic socket. So first we corrected the lid, and then we reconstruct the socket with a secondary implant. So coming to dermis fat graft, it can be primary, young patients, conjunctival scarring. Secondary, after extrusion or exposure of the implant. Here the thing is, sometimes results are not really predictable. I will show some cases after this video. Video I think I will skip, no. So here is a primary, this is a trauma, then repair done, thysis. So now actually I'm moving away from implants because I did dermis fat graft for her. I fitted with a prosthesis. The only thing, just little bit of superior sulcus deficit, but patient is not really bothered. So this is 18 months. She presented to us at 18 months. Left eye microphthalmos. You can see they were not very willing for any procedure considering the expectations for vision. So initially we started with customized prosthesis. Then by 3.5 years, she underwent dermis fat graft and followed by customized prosthesis. So this is another patient, again trauma. All cases need not require evisceration. In fact, they came for evisceration. So I told them we will just, you can see the fracture. So correct the fracture and put intracorneal fat so that the volume will corrected and will get a good alignment. So this was his picture after the procedure. This is one patient which I like to share. Bilateral retinoblastoma, status post enucleation with the ball implant in childhood. Right eye had implant extrusion. So status post DFG also in childhood. So he was under a follow-up since last almost 10 years. So this was his appearance, which he was not very happy. Now he is doing his degree courses. So his concerns, like, he doesn't have a lid crease, eye look proptotic, and eye is not closing at night. The thing is, while he was traveling in the train, somebody has picked up his keeping eyes open. So then what I did is, like, I just debugged the orbit fat a little bit. I did a frontalis sling with silicone for the ptosis just to form a small lid crease, and for the lower lid again with same silicone I did a tarsal. I did a lower lid sling starting from middle canthus to lateral canthus. So eventually he did well, so he's all right. DFG complications, poor healing and lash growth can happen. Then this is one case which I like to share. All the patients does not require any big surgeries. Again depending on patient's expectations. So he's an auto rickshaw driver. He just wanted shell to be in, but still that was also not going in. So I did a small lateral tarsography so that the shell will stay inside. So this is his picture post customized prosthesis and a lateral tarsography. And he had already received radiation, etc. So none of the surgeries is going to work also. Colored iris is also possible. A few words about congenital enophthalmos. The rehabilitation should start at birth. But most of the time, even if we tell the parents, like, no, they won't agree most of the time. They will just go from this place to that place, etc. So implants usually done less than 5 years, dermis fat graft. If the socket is contracted, you have to use orbital tissue expander, which I don't have much experience regarding tissue expanders. So this initially we start with progressively enlarging conformers. First expand the lid, conjunctiva, then you can give the volume to the patient. So this is one patient presented to us, like, I think 5th day of life, had a huge cyst with enophthalmia. So initially the shell was also not going in. So just waited till 5 months for anesthesia. Then we started putting serially increasing. Actually we made a customized prosthesis and started increasing it. And now, then later she underwent Miss fat graft, and now she's like almost 12 years and she's doing fine. The only thing, like, if you look at the lid, lower lid is fine, the upper lid is still short even after doing all these things. So congenital enophthalmia, initially sometimes the shell, nothing will go in. You cannot see also. You have to confirm with ultrasound whether any ocular structures is there or not. Then put a butter conformer, review the patient every month, serially increase. Someday you have to do a lateral canthotomy also to fit the button conformer. So I would stress the importance of protective glasses, polycarbonate CR39, full frame, photochromic tinted, and optical modulation. Sometimes if there is some volume deficit, you can mask with plus glasses. Psychological counseling is also very important. And take home message, assess the socket carefully. Reconstruction is a complex undertaking. Surgical techniques are continuing over a period of years. And the socket patients are always, once they are your patient, they are always your patient forever. So decisions is between the patient, family and the surgeon. Poorly fitting prosthesis is always a problem. And the most important thing is always protect the normal eye. Thank you.
Thank you so much, madam, for making socket reconstruction look so easy. And thank you for doing the marathon talks in the other halls in here. Next, I'd like to call upon a dear friend, Dr. Shruti Aras. She is currently doing her fellowship in oculoplasty at the prestigious LV Prasad, Hyderabad. She was very kind enough to come down all the way to give this talk today. She'll be talking about accentration and the management.
Hi, a very good morning to one and all. I think I'm the closing batsman for the day, or rather for the event. Yeah, we have one more. So at the outset, I would like to thank my friend Dr. Anju for this opportunity. The topic given to me is accentration and sequelae management. So my presentation will basically be divided into number 1, introduction, number 2, the surgical technique or the surgery of accentration, and number 3, post-accentration processes. So what do we mean by exentration? Exentration is a surgical procedure wherein you remove the intraorbital contents along with the eyeball. So you remove the muscles and the soft tissue and periorbita and everything around the eyeball. It was first described by George Bartisch, who was a German surgeon in the year 1583. So once upon a time, it was called a very destructive and crude and dirty procedure. Of course, it still remains a destructive procedure, but not probably as dirty or crude. So broadly speaking, the indications for exentration can be squamous cell carcinoma, sebaceous gland carcinoma, basal cell carcinoma, which have all gone beyond the orbit, which have got probably extrascleral or extraocular extension. It can also be done for non-resolving fungal granuloma. For the interest of time, I will not be going to each and every indication per se, but just to remember, indications can broadly be divided into number 1 neoplastic and number 2 non-neoplastic. So what are the types of orbital exentration? As the blue, dark blue, marking shows, one can be total exentration. Number 2 can be subtotal exentration, wherein you don't have to remove the posterior most extent of the, orbit till the orbital apex, especially if you have a very invasive and aggressive OSSN. You don't have to go and remove till that. And number 3 is an extended exentration, wherein you also will have to remove the bones of the orbit and sometimes the facial bones. Now moving on to the surgical procedure. We have actually come out to the lid sparing technique of exentration. Earlier, lid was not spared. And these are all the instruments which you use for exentration. I'll come to the instruments when we actually deal in detail with the surgical video. Radio frequency cautery is of utmost importance because this is a surgery which will have a lot of bleeding. So I would also like to emphasize the importance of Klein solution, which is basically used 20 to 30 ml of Klein solution is injected as a peribulbar block and around the eyeball before removal of the entire contents. So this is essentially a mixture of 250 ml of saline, 20 ml of bupivacaine or ropivacaine, 30 ml of lignocaine, it is basically 2 to 3 ampules of adrenaline as per the permit given by our anesthetist, 1 Hyalase and 1 Dexa. Here's the surgical video of exentration. So you will have to take a traction suture. This is basically the lid sparing technique of exentration. Here we are marking 4 millimeter mark with the help of a calipers so that you are able to spare the eyelid. And then with the help of a 15 number blade, you are incising the skin. So this is all done after the injection of Klein solution. So at least the bleeding will not be that bad. So the skin is dissected, then the subcutaneous tissue and orbicularis oculi are dissected with the help of a cautery. And this is usually done, towards the orbital rim. Now the yellow structure you see is basically the orbital septum. Care should be taken not to injure the orbital septum. If you breach the orbital septum, then the preaponeurotic pad of fat and all the orbital fat will come out. Medial and the lateral canthal tendon area is also excised. And then keeping a lens spatula, palpating the orbital rim, 4 millimeter away from there, you start dissecting and try to reach the periosteum. So this is done all around, superiorly, laterally, inferiorly and medially. Now this is a periosteal incision, again taken with the help of a lens spatula held with the left hand, and the periosteum is lifted away with the help of a periosteal elevator. Usually this is done slightly lateral to the supraorbital notch because there will be a lot of bleeding near the supraorbital notch, so that is dealt with later. Now you go all around. This region is basically the lacrimal sac region. We see that the supraorbital notch region is also reached, and you also encounter a lot of vessels and nerves like the zygomaticofacial, zygomaticotemporal complex. You see the infraorbital neurovascular bundle there. So this is the lacrimal sac which is taken back, and the nasolacrimal duct is cut basically. So at this stage, you can actually go to a lid. At this stage, you can pull it out and then try to be safe and cut the optic nerve and all the other tissues. With the help of a cautery, all the other bleeding vessels are seen, and this is a cellulose sponges kept over it, and this is a very good time when you can actually explain the landmarks to the juniors who are all there in the theatre, like the lacrimal gland, lacrimal sac, the infraorbital foramen, infraorbital groove, and all that. With the help of a 4-0 vicryl, we close the subcutaneous tissue and the orbicularis oculi muscle basically interrupted. And with the help of 4-0 proline sutures, we take a continuous interlocking pattern to close the skin as well. Finally, we have to put ointment and pressure patch it. Yeah, before that, you'll have to take out all the air and residual blood which was collected. So finally, the socket has to be concave. And the post-op care, we usually admit the patient for 2-3 days. We try to aspirate daily. We don't put a drain, in fact. So when the aspirate is less than 4.5 ml, we discharge the patient. So till then, the patient will be kept admitted probably for 2-3 days in our ward. So after an excenteration, what is the second story? It is important that you provide the patient with post-excenteration processes as well. Conventional orbital processes have been of two types. Number one, spectacle mounted, and number two, adhesive retention or glue retented. So they had their own disadvantages. The spectacle mounted usually will come out along with the spectacles, and there was no seamless appearance with the rest of the soft tissue. When the patient looks down or bends down, it will come out when the spectacle falls down. And the second one, which was glued or adhesive retention, would usually last for only 4-6 hours, and then it will start peeling out from the edges. Also, allergy due to this particular glue, like allergic dermatitis and irritant contact dermatitis, was also seen in a few patients. So this actually has sort of created an avenue for us to move on more into what is called an osseointegrated processes. So now what we do by far is the osseointegrated processes. What is osseointegration? Apart from oculoplasty, this has been used in multiple other specialties, like in dental implants, in BAHA or bone adhered hearing aid, and in implant retained processes. So these are essentially titanium implants which are screwed into the bone, and they have a magnetic property. So the reverse pole of these magnets will be fitted into the orbital processes so that the orbital processes can be snugly clicked on and clicked off. I'll just run a short video on osseointegrated implants. It is broadly divided into step 1, step 2, step 3. Step 1 and 2 are surgical, and step 3 is basically the processes. Here is a simple animated video showing the surgical procedure of osseointegration. 3 to 4 titanium implants go into stable bone where osteotomy is already made. These implants have a magnetic property. The reverse pole of these implants is incorporated into the processes. So the processes snugly clicks on and clicks off. The process of osseointegration is a 3-step process. Let us move on to the osseointegrated step 1. With the help of a soft tissue template, the skin marking is made and joined together. Local anesthetic agent is infiltrated subcutaneously. Skin incision is made with a radiofrequency cautery. Progressively, the subcutaneous tissue, orbicularis oculi, and deeper tissues are incised with a radiofrequency cautery in order to reach the periosteum overlying the lateral orbital wall. Now, the periosteum is lifted away from the bone with the help of the sharp end of a periosteal elevator. Bone template is placed on the bone to help orient the direction of drilling. Pilot holes are drilled followed by sequential parallel twist drills in order to widen and deepen the osteotomy hole to the required size. Bone drilling is done perpendicular to the bone as it will affect the trajectory of the implant. Also, copious irrigation is given during drilling to avoid the dermal bone injury that can affect osseointegration process. Now, the implant is inserted into the osteotomy after checking its depth and trajectory. Cover screws are inserted into the implant to avoid soft tissue entrapment and epithelial ingrowth. Periosteum is sutured together with absorbable sutures, and the overlying skin is closed with 6-0 vicryl interrupted sutures. the end of step 1, the implant is placed inside the osteotomy and cover screws are placed on top of the implant to prevent epithelial ingrowth, and the skin is closed over it. After a wait of roughly 2 months for complete osseointegration, now it's time to consider step 2. The cover screws are palpated over the skin and the skin markings are made. Local anesthetic agent is infiltrated subcutaneously. With the number 15 blade, small skin incisions are made to expose the cover screws, and the cover screws are removed gently. Healing abutments are placed inside the implants now in order to form a fistula around the implant. So the basic concept behind step 2 is that the cover screw is removed from the implant and healing abutment is placed in order to form a fistula and is exposed to outside. Step 3 is the fabrication of ocular prosthesis in the ocularis laboratory. This happens after 2 weeks of step 2. As oculoplastic surgeons, it is imperative that we handle the disease and its iatrogenic repercussions. So that was about osseointegrated implants. This was one of the recent advances. I would just like to summarize that I just dealt with number 1, what was exentration, the indications and the type of exentration. I just showed a surgical video of exentration and tried my best to tell you the steps of the surgery. And I also told about spectacle mounted post-exentration processes, adhesive retention processes, and osseointegrated implants. Thank you.
Thank you so much, Shruti, for that excellent presentation. I think we do not have any more doubts on exentration. And in fact, that was also her award-winning video that we got to see on osseointegration.
Next, I invite our own ocularist, Mrs. Celia. She did her fellowship in optometry and ocularis in prestigious LVPI Institute, and currently she is working in many places in northern part of Kerala as well as in Coimbatore and Bangalore. She'll be talking about prosthetic, all you want to know about the prosthetic eye.
Thank you, Dr. Indu. Hi, good afternoon, everyone. Mostly non-faces all. Actually, in 8 minutes, I don't know how much I can tell about the prosthesis, know all about prosthesis. And this is like ocularistry field who deals with ocular prosthesis. And ocularist who is specialized in fabrication and fitting of ocular prosthesis. Usually in 5th century, people always have disfigured parts in their face. So they, in ancient times, in Roman and Egyptian, they used to cover with something over the socket or inside the socket. So they used to use that clay, painted clays or painted clothes in front of the socket. And then in the medieval century, we invented metal. So gold with colored enamel they used to use. And in Germany, glass blonde techniques happened in Germany. So glass they used to use. But for the glasses, always we have a disadvantage. It can break and it can cause some irritation in the skin. So and then nowadays we are using medical grade acrylic plastic. It's a very good material, PMMA, polymethyl methacrylate. And nowadays we use even 3D irises also in ocular prosthesis. Stock eyes, this is like ready-made eyes in all clinics. Maybe all ophthalmologists will have one case. We'll have a different varieties in different shapes and sizes. And if we don't have any other customization option, then we can go for this sometimes. And let's see that what is the advantages of custom-made prosthesis over stock eyes or ready-made eyes. This is absolutely prepared according to the socket measurement and made up of good grade plastic, PMMA. And always this will decrease the discharge and discomfort and good symmetry with the other eye. You can see that the difference between the stock eyes and customized one. In the first one, we can see that we corrected ptosis with the customized prosthesis. And the second picture, we have a very with a stock eye or ready-made eye, we won't be able to get a good symmetry. And you can see with the customized one. And we'll get mostly we'll get good prosthetic movement if we have a very good measurement and very good socket impression. We mostly will have satisfied movements. And this is like a socket expansion we do with, we have seen in previous presentations. We use very mild buttons from the starting for a congenital anophthalmos or a microphthalmos, and we gradually increase the size of the conformer, and then we will get a, at the age of 3 or 2, it depends upon the patient, sometimes we'll get a very good cosmosis. And this is scleral shell. Sometimes we, in atrophic bulbar pre-thesical cases, we don't get enough folium. We'll get a very thin prosthesis that we called as scleral shell. And when we come to the fitting process, there are some key factors we'll see for the eye fitting. That is mainly size of the eye and shape, color, pupil size, and iris color. Sclera color, and the background of the sclera will have some kind of color, and even veins, and if any patient have a particular pterygium or any arcus, any kind of pigmentation in the sclera, we'll see that also. Usually we'll start with the evaluation of the socket that Dr. Shebin already talked about. We have a complete performer for a socket evaluation. From the, if the patient is having a prosthesis already, we'll assess that prosthesis. If it is a stock eye, we'll assess that also. And movement, socket volume, everything. After that, we'll take an impression with the alginate, which is hydrocolloid material. Even we use sometimes silicone impressions also, if we want to stock it for some time. And this is alginate. We'll have an impression trace with a different size and shapes for the right and left eye. We'll select according to the socket evaluation. We'll select a impression tray, and we'll inject the alginate into the socket, and we'll get within 1 or 2 minutes, so we'll get a very solid impression. And after that, we will make, with that impression, we'll make a wax model with a medical grade wax, which we can insert into the socket, and we can see the shape and size of the eye, and even in the alignment also. So we'll decide in this wax modeling, we'll decide the size, shape, and alignment, everything. And then that this wax model will convert into a PMMA material. And after that PMMA, we'll make a iris also. In that PMMA, we'll make iris. We'll paint the iris with the patient only, and we'll attach with the pupil button. And after that, that pupil will be attached to the PMMA, the whole size. And then after that, in that sclera, we will color all these details, even the limbus detailing. And the sclera, even if that patient have any pigmentation or any dilated blood vessels, everything will do in this step. And after that, over that, we will cover this with a clear PMMA coating, and then we can dispense that patients after all the polishing. For the care and handling, we have 2 techniques. So we can use hands to take it out and put it back, and also the plungers also we can use. I usually, personally, I won't prefer this plunger, because always the patient will have some kind of water content inside the plunger, and they will come with a fungal infection or something, because they never wash these plungers, and they don't deal with this. So, and we can, I just written this clean the prosthesis every day is ideal. Sometimes it is not ideal, because if the patient is not going for any kind of construction work or any dusty area, then they can just take it out with once in 2 weeks. It will be also good. And sometimes if the patient is in a very comfortable room, and they're not going out and not dealing with any other things, then we'll say that once in a month also, if they can use a very good refreshing tears, any lubricant eye drops 4 to 5 times in a day, then that will be great. Usually people won't have any problem with this. And sometimes once in a month or once in 2 months, they can use a mild baby shampoo to clean this. And usually we'll say that in every 6 months, the prosthesis should be polished professionally, because they will have some kind of deposits in the back side of the prosthesis, or even some scratches in the front side also. So it should be polished at least every 6 months, and compulsory once in a year they have to polish it. and when to replace it. Normally, this PMMA is a very good material and that lasts for years, 10 years or 15 years they can use without any problem. But sometimes even in the changes in the socket also happen. So that time, if the patient is not happy with the cosmesis, they can go for a new one. And sometimes recurrent infections after polishing also they are dealing with the same infection, then we can go for a new one. Or dryness, discomfort, and even any kind of size difference, and the patient is having a ptosis experience, then we can go for a new one. And sometimes popping out very frequently, a patient used to complain about this. It will come out easily because the socket is big and the process is small, then they'll experience this problem. Then that time also we can go for a new one. If no other problem happens, they can every 6 years we'll say that to change the prosthesis, but often they come to us after 10 years sometimes. So these are some patients. And we sometimes not all, every time the process will be in a good size. Sometimes it will be small and big, even though after the surgical correction we'll get these kind of problems. So we can use mild these kind of optical illusions. We can give plus power to enhance the size, or minus power to minimize the size. We can use the even prism also. In some axis we will get a very good cosmesis. And thank you.
Thank you so much, Celia, because for taking us through that journey, because we always just refer patients to you. We do not actually know what happens in your work area. So thank you all for being here till the very end. Any questions for the speakers? I know you're all very hungry. Any questions for the speakers? I have just one question to Shruti. Is this osseointegration a very expensive procedure? Because if we have patients who are interested in them and we would want to refer.
So thanks for the question, because we had a lot of mucor patients who had undergone accentration. That is when Dr. Tarjani actually started doing osseointegration. I think so far we have done some 45 patients for whom we have done osseointegration. The osseointegrated implants. Main thing is we've been getting a lot of funds and grants. So because most patients, are non-paying, so that gets covered in that. But otherwise, I think it is almost 2 lakh, the whole thing, if they have to, the prosthesis part and all that. Surgical, I'm not very aware of, but I can get back to you. But I think 70 to 80% are all grant and, trust patients.
No, so if we are to refer patients there, will they also be,
Yeah.
will they get the grants too?
Yes, they will.
Shruti, just very nice presentation. One more question. Any particular reason not putting a drain after accentration surgery?
So I have never seen a patient whom drain has been put for. We only put drain if we do some iliac crest grafting and all for a whole facial reconstruction. That's the only place where I've that too, because we have taken an iliac crest harvest. I've seen drain that way, but till date I've not seen a single patient for whom we have put drain. So this is the way we have been taught, and this is how we do post accentration. So on table you saw once we aspirate. Then from the next day, daily morning we aspirate. Morning when we see the patient, we aspirate.
Aspirate with which
We
gauge?
aspirate with 18
gauge
needle
Thank you.
attached to a 10 ml syringe. So mostly I've seen on day 1 10 to 12 ml, day 2 then it becomes 8 ml. So that is how we have seen. I don't know what outside.
Sorry, one more question.
Yeah.
Pain.
No, not at all. No. Yeah.
All their nerves are already severed, no ma'am. So I
Yeah,
don't
it
think
is
they will
not
have-
at all pain. Nobody has ever told there is pain. So we are doing it very close to the skin suture that you put, and I've never seen anyone, because वैसे patient will have pain, no, post surgery. So I don't know whether the.
Probably our NLGC will take care of that too. Okay, so thank you so much. We'll have all the remaining discussions in the lunch area. Thank you once again. Can we have a quick group photo?